I will say this. I do have kids that go into the emergency room. Like, I had a young gentleman who was 15 and he got shot in the shoulder. And he came to my office the next week with Vicodin and OxyContin that he had gotten in the emergency room, both of them. And the doctor told him, well, if this one doesn't manage your pain, try this one. And, you know, so I have to kind of a little bit agree with Travis in the sense that I think that as physicians, we need to have a little more training. Because we're just giving it out like, well, I mean, try this, and if this doesn't work, try that.
But that's different than saying that it's not, that the right dose is not the dose. We're saying be trained in managing pain and prescribe judiciously. We're not saying, well, nope, you're still in pain. Sorry, because that's the dose.
My point is, when we are in a day and age where the third leading cause of accidental death is prescription drug misuse, prescription legal drug misuse, you know, in some ways, that's when we got to step back and say, okay, if we're going to approve these medicines, which I'm fine with, by the way. I do not believe in withholding pain medication to an 11-year-old who is in great pain. But when also 1 in 25 high school seniors has abused OxyContin,
it's a problem.
That's a little scary.
I mean,
it's a big percentage.
Well, it's scary because you wonder where they're getting it from. That's the thing.
Well, did we really need a stronger, more powerful, more addictive pain medication? I mean, were we lacking something?
We did, because when it comes to pediatrics, there's only one extended-release opioid that's even approved, and that's a Duragesic patch. So we actually did need, you know, a couple more tools to manage this pain that some.
But I think it does speak to, and people listening out there who are suffering from chronic pain do need to understand that there is a menu of options. It's not just opioid narcotics, non-steroidal anti-inflammatories, a lot of complementary therapies like acupuncture can be very, very helpful, and they can work synergistically. So it's not either OxyContin
relaxation,
or nothing.
meditation.
Absolutely.
And they are, fortunately, in more and more of these narcotics, the way they're made by the manufacturers, they are more tamper-proof because, you know, particularly children, to get a high, they may learn to crush it, and then you can snort it, inject it, which gives you a quicker, more powerful high. And the takeaway really is for the patients themselves or parents, which is, you know, ask a ton of questions. And at the end of the day, if you're not comfortable with your doctor and how they may or may not be prescribing these, go to a specialist. There are people whose sole job is managing pain, and they certainly should know these medicines more than anyone else. The FDA did give us a statement. It's important to stress that this program was not intended to expand or otherwise change the pattern of use of extended-release opioids in pediatric patients. Doctors were already prescribing it to children without the safety and efficacy data in hand with regard to the pediatric population. We wanted to fill that knowledge gap. Seems to make a lot of sense to me. And as with all medicines...
And I just want to say that I think our patients need to understand that when we say no, we try to limit how much, what type of pain medication. I mean, we want you to be pain-free. We want you to be comfortable, but we don't want to start a slippery slope where we get you going. We don't want you having excess pills lying around that you're going to misuse,
or that
somebody else is going to misuse.